hear me clearly. I will provide a brief update on the current status of the PHC and adult hospital chapters reviewed in the current cycle, which is the 2020 to 2024 review cycle. And I will also briefly outline how these documents can be accessed through the available platforms. Can everyone see my slides in presentation mode?
Yes, you can see. You can continue.
Okay. Thank you. Just a brief orientation of the STG editions which are currently available for access. The last edition of the Adult Hospital STG is the 2019 edition, and the last PHC STG is the 2020 edition. So both these editions are available on the National Department of Health Knowledge Hub and NHI web pages. They are available as full editions in a PDF file comprising of all the chapters reviewed in those cycles. It is also important to note that the 2020 to 2024 review cycle is still in progress. And what is notably different between the current cycle and the previous iterations is that the current cycle is a combined review where both the PHC and the adult hospital STGs have been reviewed concurrently. So NEMLEC was cognizant that delaying publication of these editions until the review of the complete cycle was concluded could delay access to the content. So therefore, individual chapters are now published when they are finalized, and they then replace the corresponding chapters in the previous editions. So for the adult hospital level in this cycle, we have published 10 chapters and 9 are still under review. And for the primary healthcare level, we've got 10 chapters that are published and 11 are under review. So what you see on your screen are the chapters that have been published in this current cycle. For the primary healthcare level. And just to reiterate that this is a very iterative process, and the chapters are published in the current cycle. Some chapters that are published in this current cycle have already been updated. And these updates are prompted by many considerations, such as the changes in evidence base, and even price changes can prompt changes in these chapters to be updated. So what you now see on the screen is the adult hospital chapters that have now been published. And moving on to where we've been in terms of the webinar series and what we've covered thus far and what will be in the pipeline. So if you can all remember, session 1 was the HTA session, which covered health technology assessments, and we're privileged to also link up with colleagues from the National Institute of Health. And we also ran through the NEMLEC process and the evidence to decision framework in the selection of essential medicines. And for session 2, which was held on the 16th, we covered changes to the mental health chapters. And in the next session, which is still coming up on the 13th of August, we will be covering changes or focusing on critical care, which is a new chapter and has been developed for the adult hospital STG. And then how do you access these documents that have been published? We have provided URL pages there for the NHI web page and to the Knowledge Hub e-library. And you can also access the content through the EM Guidance mobile and desktop application. And also, if you've got questions regarding access or the content or anything really, please do give us a link up on the email address provided there. We're able to assist with any queries that you might have. And in terms of resources, I just wanted to highlight that some of the content that we published includes the NEMLEC bulletin, which aims to provide a summary of important information following each NEMLEC meeting. So look out for the NEMLEC bulletins that are published just to know what's happening within the NEMLEC space. And we also publish circulars for dissemination to stakeholders. For instance, if we've got a notice for external comment, we will publish that. And also in collaboration with our colleagues from the contract management unit, we also publish circulars for out of stock and other issues. Next slide. So those are just ways to access the Knowledge Hub page. You can use that QR code, or you can Google it and use the keywords that are suggested there. And then in terms of how the layout of how it looks, not only do we publish the chapters, but we also publish the technical documents that accompany all the published chapters. And if you need information on governance documents, it's also there. And the list of the NEMLEC members can also be found there. Also, so this is how it looks. This is the layout of the uploaded content, and you can also see that it applies to all levels of care. So what I wanted to touch on is, as you know, the Essential Drugs Program falls under the NHI branch. So we are trying to incorporate all our content to the NHI webpage as well. So it contains everything you'd find on the Knowledge Hub, minus the historical documents. So this will contain all the latest updates. So we encourage you to please check it out. It's very easy to navigate. And as you can see, it's also the tabs for different levels of care. So it's arranged in terms of levels of care, which is very easy to use. And then as we're looking for better ways for ease of access to these documents, we've also will be creating an index, which will be published soon, that is showing all the status of the chapters. So this will be sort of a directory where we are able to see where the STG cycle review is at. So that is just an example of how it will look like. So please do engage when it's up so that you have access to the latest material. Thanks, Chair. That's my story.
Thanks, Mariping. And I think that's given people a useful introduction to where we are in terms of our progress of trying to give people more access to the information that used to appear periodically in booklet form. It is a work in progress, and we'll keep you up to date as things change and develop. I think we can now move on to our main speaker, who's Professor Stefan Gebhardt, and he's going to lead us through some of the issues around the ONG chapter. Thank you, Stefan. Over to you.
Thanks. I'll just wait for Mariping to start the slide set, and then we can proceed. So while we're waiting for the slides to load, I can maybe just say in the interest of time, we're going to discuss 5 new items in the standard treatment guidelines. The first is tranexamic acid for postpartum hemorrhage, which is also now available at primary healthcare level. Asprin for production or prevention of preeclampsia in high-risk patients, also now available at primary healthcare level. Tenofovir prophylaxis for hepatitis B positive women who are HIV negative, and we'll go into detail of that. Just a recap on progesterone for preterm labor. It was available in the previous edition, but there wasn't a drug on tender, so not a lot of people have implemented it yet. And then we'll just finish with the levonorgestrel intrauterine device, which is now also available at primary healthcare level for family planning.
Sorry, Prof. We seem to have lost Maruping. Is anyone else in the group have the Prof's presentation? Or Prof, are you able to find it?
I can share slides from my side, but my slides look a little bit different because they're highlighted. But let me just share them then.
Prof,
We can bring
to project for you quickly.
Thanks, Maruping. It's Millie. I'm here if you need me to bring it up.
Thank you, Millie.
Millie, you can go to the slide on tranexamic acid, and we can start straight away there. While the slides are coming up, just to give you a background, tranexamic acid has been reviewed for inclusion in the primary healthcare chapter 2020, but it was not included for management at primary healthcare. It was approved for inclusion in the adult healthcare. But the challenge with that is that you need to start tranexamic acid within 3 hours of postpartum hemorrhage for it to be effective to help with reduction of the blood loss. And the challenge is that by the time the patient gets to the next level of care, that critical 3 hours may have passed. So an appeal was given to NDOH to reconsider tranexamic acid for primary healthcare level. And the challenge was that generalizability of the evidence on which the tranexamic acid was based, that was the women's trial, that was not specifically for primary healthcare settings, that was for emergency hospital settings, and also price was a major consideration. Thanks, Millie. So you can go to slide 6 now. That one, yeah. Thanks. So the motivation was then, or appeal was then motivated to NDOH. And also in that appeal, the original price of the tranexamic acid was wrongly calculated, so it is actually cheaper than we thought. So NDOH then said that we should review the evidence, and at that stage, the large emotive trial was still ongoing, and the emotive trial was published in 2023, and that provided the updated evidence that we needed to extrapolate the use of tranexamic acid to primary healthcare level. Next slide. This is just an overview of the emotive trial, and as you can see, that is a bundle of interventions to reduce postpartum hemorrhage, of which the first E is for early detection, which is actually the most important, is to really diagnose postpartum hemorrhage early on. And for that, calibrated drapes are used, or just a very high level of clinical judgment, but calibrated drapes are better. Massage of the uterus as soon as you start to bleed, oxytocic drugs, all of these are standard. But then the T is tranexamic acid, and I'll come to the dose. IV fluids, and the last E is for escalation to the next level of care as soon as possible. Next slide. Thanks, Millie. So just to say that this evidence has been done in this trial has been done in lots of hospitals all over the world, but South Africa was involved. That bundle of care shows that if you give tranexamic acid at district level already, it reduced postpartum hemorrhage by up to 60%. And because it was done in our own hospitals at district level, the results of the study can be extrapolated. All interventions started as soon as possible, and women urgently transferred to the next level of care so they can come under specialist care. Next slide. So after the appeal and the evidence, NDOH supported the use of tranexamic acid 1 gram IV, slow injection or infusion in 200 ml of saline over 10 minutes for postpartum hemorrhage for all levels of care. It may be initiated by a nurse, but with prior approval of a medical practitioner. So that means at least it's available at primary healthcare level. If they phone for referral of the patient, you can already ask them to start use or start administering the tranexamic acid. Next slide. Just to show you the changes that was made in the standard treatment guideline. So just to remember that that slide, just to remember that you still need to give the 10 units of oxytocin for delivery of the placenta, that is standard. But if a PPH is then early detected, the postpartum hemorrhage, start with immediate replacement fluids, which is sodium chloride, and diffuse as fast as possible. And in a second line, give 20 units of oxytocin, also infused at quite a high rate, 150 mL an hour. And then give the tranexamic acid, the dose I've said before, 1 gram slowly, either in 200 ml or just slowly IV. And it can be initiated by a nurse as long as it's priorly approved by a medical practitioner, either in protocol or telephonic referral format. That is about tranexamic acid. Let's move to the next slide then. Okay, So now we had aspirin for reducing the risk of preeclampsia in patients that is at risk for preeclampsia. So we all know that patients with hypertensive conditions, existing hypertensive conditions prior to pregnancy have a high risk of superimposed problems in pregnancy, especially early onset preeclampsia. And a low dose of aspirin given very early in pregnancy helps with the early placentation formation and the reduction of the risk of early onset preeclampsia. So historically, aspirin was available, namely approved that at regional level in women with chronic hypertension, as all women with chronic hypertension are referred for secondary management as soon as possible, because they need to be switched to safer medications, and then the aspirin can also be initiated. But the challenge is that there is sometimes a delay in the transfer, especially if you look at point number 4 there. Patients just have historical risk factors. They had preeclampsia in a previous pregnancy, but they're currently fine. They don't have hypertension now. They are still at risk of developing preeclampsia, but they're not an urgent referral. They will only be referred around about 20 weeks. And at that stage, we've lost the window of opportunity to start aspirin early. So the appeal to NIMLAC was then to review the evidence and to make aspirin available also at primary care so it can be initiated early on. Next slide. We know that aspirin is safe in pregnancy. There's been large trials on that. Maybe if you can just go to the second slide there. So the safety has been established. There's a slight risk of bleeding, and that bleeding is during delivery or postpartum. So we can mitigate that risk by stopping aspirin at 36 weeks. Also because it is early onset preeclampsia that we try to reduce. So about 36 weeks, it is not effective anymore, so we can stop it. If you look at the guideline alignment, the green block there, the National Maternity Care Guideline, as well as the international guidelines that we use, all recommend aspirin to be used at bedtime to prevent gastric irritation and to start as early as possible, already from 6 weeks of gestation, because it's really in the first trimester that it has its effect. So preferably before 16 weeks and then to stop at 36 weeks. So the recommendation that was accepted by NIMLAC was then to use aspirin 150 milligrams orally for the reduction in the risk of early onset preeclampsia at pregnancy, and it can be used at primary healthcare level for nurse initiation in line with the existing guidelines. Go to the next slide, please. Just to say that NIMLAC has recommended that. And if we go to the last slide, we can just see the changes in the SDG. And that's exactly taken from the text. So from confirmation of pregnancy for all women at risk, and those risk factors include preeclampsia in a previous pregnancy, current chronic hypertension, current diabetes, or your more advanced antiphospholipid syndromes or SLE. Aspirin to be taken 150 milligrams, half a tablet at bedtime, preferably not an empty stomach, stop at 36 weeks. Start at 6 weeks, preferably before 16 weeks. And then refer to the next level of care as appropriate. But if it's just a prior history of preeclampsia, the patient can be started on the aspirin and be referred for the next appointment. According to the bank schedule, that would be around 20 weeks, which you can also get a detailed ultrasound. Okay, so that takes care of aspirin. Then we can go to the hepatitis B. So hepatitis B screening, as you may know, has been initiated routinely in antenatal care in South Africa. We're in the process of implementing it, so all the teething problems have not been sorted out yet. It is already being implemented in women on the HIV positive program, but we're still working towards hepatitis B positive women who are HIV negative. And most of this information is based on the new WHO organization guidelines. This has been updated in 2024. So what we're dealing with at this stage is the HIV negative women who is hepatitis B positive. And the challenge here is tenofovir prophylaxis. If we start tenofovir prophylaxis in around 28 weeks, it reduces the risk for transmission of hepatitis B to the baby. And all of this has to do with vertical transmission prevention. So tenofovir monotherapy are specifically in this case for hepatitis B positive, HIV negative women. We know that the risk is higher if the HBe antigen is positive or if the viral load, the hepatitis B viral load is very high. And especially those women need to be targeted for tenofovir prophylaxis. But it is a challenge to get those results, especially in smaller clinics. And also now in the 2024 WHO guideline, they recommend that we can pragmatically offer tenofovir prophylaxis to all women who are HBs antigen positive, even if the other results, the HBe antigen or the viral load is unavailable. And then that last bottom bullet there, in case of women with impaired kidney function, and that includes pregnant women, tenofovir alafenamide is an alternative because it's more renal friendly. Next slide, please. So just talking about renal impairment in pregnancy, pregnant women with renal disease is quite at high risk, either for developing superimposed complications, especially preeclampsia, but also for progress of renal disease, and even sometimes renal disease is so severe that pregnancy should not continue. So this comes from the maternity care guidelines. So any woman with renal disease should be referred to a specialist to evaluate for the presence of renal impairment, the severity of the proteinuria and hypertension. If it's very early onset, they should be referred to tertiary care. And as I said, if pregnancy disease is quite advanced, if it's stage 4 or 5 chronic kidney disease, pregnancy is contraindicated, and recommendations on termination of pregnancy for the maternal safety should be considered. So this means that all patients with renal impairment will be referred to at least specialist or tertiary care level. And in that case, if they do continue with the pregnancy and they reach 28 weeks and tenofovir is needed for vertical transmission prevention, then the alternative TAF or tenofovir alafenamide can be used. Next slide, please. So this is now the changes that is in the standard treatment guidelines under hepatitis B positive, HIV negative women. The most important message is still that these women should deliver in a facility that can give birth vaccines, active and passive vaccines if available, so immunoglobulin if available, but at least birth dose of hepatitis B vaccine. And that is in that bullet as well. So if you just look at that whole block, I'm not going to read all the text, but all pregnant women who are hepatitis B is antigen positive, or have got more advanced disease, but are HIV negative, are eligible for pre-exposure prophylaxis, so for PrEP. And for that, the guideline refers to the PrEP section. Now, we may have a woman who is HIV negative, hepatitis B positive, but who declines PrEP. Remember, PrEP contains tenofovir, so that will cover the vertical transmission prevention as well. But if they decline PrEP, we can still counsel them that tenofovir will reduce the risk of vertical transmission to the baby, especially if the e antigen is positive, the viral load is high. And the dose then is tenofovir 300 milligram daily from 28 weeks of pregnancy until birth. For those categories, either high viral load, e antigen positive, or pragmatically, where we don't have the results available, we can also start tenofovir at 28 weeks. Once the baby is born, the standard treatment guideline refers to the relevant section in the pediatric STGs. If you need to stop the tenofovir, it's good just to obtain a specialist opinion, because there is a risk for postpartum hepatitis flare. And women may also benefit for continued treatment if they're in a special category. And again, the guideline then refers to the chronic hepatitis B outside of pregnancy for further management. And then just that bottom bullet again, renal dysfunction. So that's a reason for referral. And again, just a reminder that TAF is available in the place of TDF if needed to be prescribed. Thanks. We can move to the next slide. So now we are at progesterone for preterm labor. As I said earlier, this was already available in the previous edition, but this is just a recap so that we can look at this again. We had a medicine review on progesterone to prevent preterm labor, and the key findings are all there, and the full review The link is at the bottom, so I'm not going to go for the full review. I think we can go straight to the next slide. And that is the NIMLAC recommendation on daily vaginal progesterone treatment up to 34 weeks of gestation. So this is now for women at high risk of spontaneous preterm labor. And I'll come back to that again, but it's spontaneous preterm labor. So it's not a previous pregnancy that was induced for hypertension in pregnancy or that delivered due to complications like twins. This is a singleton pregnancy where there was a spontaneous mid-trimester miscarriage or spontaneous preterm labor before 34 weeks. And the evidence shows that for these women, progesterone may help to prevent spontaneous preterm labor in the index pregnancy. So there are two categories of women. There's the women with a short cervix, and that's defined as a cervix that is less than 25 millimeters before 24 weeks gestation. And this is measured by vaginal ultrasound, so it's a specialized investigation. The other category is women with just a history of spontaneous preterm birth or trimester loss. So we don't recommend routine cervical screening in low-risk women. It's not cost effective, and this is really only for women who are at risk. So if it is incidentally picked up, or if there's a reason to do a cervical length and it's short before 24 weeks, that woman or that person may benefit from progesterone. Or if she has a history of spontaneous preterm birth or trimester losses. Just go to the next slide. So the rationale for recommendation is then that the evidence review showed that based on the NICE guideline, all the systematic reviews and meta-analysis, there is still a bit of conflicting results regarding progesterone. But if we look at subgroup analysis, and those groups are specifically mentioned now, the women with a history of spontaneous preterm birth or with a short cervix, in that case, vaginal progesterone did decrease the number of preterm births when compared to a placebo. And we're looking at births before 34 weeks gestation. So the alternative to progesterone is a cervical cerclage, which is surgically put into the cervix like a burr string suture to close the cervix. So cervical cerclage is an invasive procedure. You need hospitalization. It's an introduction of a foreign body in the cervix. It needs to be removed at 36 weeks. But that is an alternative for specific women with also the risk of preterm labor. But if you compare the two, vaginal progesterone is non-invasive and it is less costly compared to a cerclage. Next slide. So this is how the new standard treatment guidelines look then on progesterone for preterm labor. And if you look again at the recommendation on top, it gives us there the numbers needed to treat, which is always important if you want to counsel a patient. So in terms of cerclage, the numbers needed to treat are 17 to 20. And for progesterone, it is 6 to 8. So that can help women make an informed decision between cerclage and progesterone, because you need to put in one cerclage or 20 cerclages to get one pregnancy past 34 weeks, whereas you need to treat 6 to 8 with progesterone to at least get one more than 34 weeks. So either of the two, vaginal progesterone or cerclage, that's the old McDonald's suture, can be given to women with a history of spontaneous preterm birth, and now they've got a short cervix. So you'll see that it says and or. So ideally, it is a history plus a short cervix. But because it's difficult to do cervical length if you don't have ultrasound available, the option is here just to treat women that has a history of spontaneous preterm birth or mid-trimester loss. But ideally, the best candidate is the one that has got both the history plus a short cervix. And they benefit from progesterone 200 milligrams vaginally daily, and be stopped at 34 weeks. And if that stage, if all is normal, the patient can be referred to a lower level of care because the risk for preterm labor is now gone. The cerclage, then we reserve specifically, and the recommendation is there for women with a short cervix and where you really suspect that that cervix is incompetent due to either prior surgery, like a cone biopsy, or a history of preterm pre-labor of ruptured membranes, PPROM, because that points more towards incompetent cervix than spontaneous preterm labor. So we reserved cerclage for women, specifically where there's a short cervix with a previous damage to the cervix. Then there's two other types of cerclage, which is also mentioned there, the rescue cerclage. So this is at a later gestation, if you maybe missed the boat early on with progesterone or with the early cerclage, and now the membranes are already bulging a little bit, the cervix is already open. Up to 27 weeks, a rescue cerclage can be put in. This again can be removed at 36 weeks if the pregnancy is successful. And then the last one is the woman that needs to be referred to tertiary care. So if they had a previous cerclage that was torn out or there were severe cervical tears, we need to put the cerclage a little bit higher. So it's an abdominal cerclage that's placed. And this is done either laparoscopically or laparotomically at tertiary care. So this is just a refreshment on preterm labor and the prevention of preterm labor. It's quite an important risk factor for prematurity and for fetal death. So it's important that people are aware that the drug is available, progesterone is available at the hospital level of care for reduction in the risk of preterm labor. Okay, then we can move to the next slide. And now we get to levonorgestrel intrauterine device, the so-called Mirena or levonorgestrel intrauterine device. And just as I said, it's now available for family planning and primary health care. So let's just go through the history of how this happened. So just as a reminder, levonorgestrel is in the intrauterine device or intrauterine system. It looks like a copper IUCD, but it has that body of levonorgestrel. It thickens the cervical mucus to prevent sperm from reaching or fertilizing an egg. It's very lots of advantages. It's highly effective. It can stay in for 5 years. You do not require any monthly monitoring. The only con is that it is very expensive. It was very expensive. So in 2015, NIMLAC recommended that the levonorgestrel device can be used for that was as we first tried contraception, not for contraception, because the evidence was there, but it was very expensive. Then we did a health economic analysis in 2018, looking specifically at abnormal uterine bleeding. And then it was included in the standard treatment guideline as a third-line treatment option at tertiary and quaternary level of care for refractory abnormal uterine bleeding. And we continued the motivation for Mirena to be used, or the device to be used for contraception. At 2020, still also NIMLAC said there's an alternative device, the smaller device with only 90 milligrams, not to include that because that one is still very expensive. But if you go to the next slide, this was the rationale that we used to consider it for inclusion. So we do have contraceptive supply challenges from time to time. We don't have a very wide choice. And that means that the increase or the uptake of contraceptives have not substantially increased. So if we have more options, then we have a broader base to choose from. And it does have advantages over the copper intrauterine device in that it also treats painful menstruation, which is quite a common problem, especially with teenagers. So it does decrease menstrual blood after about 3 months of use, and it also decreases menstrual pain, as well as the risk for pelvic infection. And then the company reduced the price. So it made it much more affordable to use. You can go to the next slide. And then finally, with the reduced price, NIMLAC recommended that it can now be included in the primary healthcare standard treatment guidelines as a contraceptive option. Still only the 52 milligram device, not the smaller 90 milligram device, because that one is still quite expensive. But that one is available on the therapeutic interchange database as an alternative option if we say need to be able to use that. And then NIMLAC also recommended that we just monitor the discontinuation rates and make sure everyone is trained in the insertion of the device. And the continuation or discontinuation rate is quite important because if it's removed after a few months, we lose that economic advantage. If it is used for the full 5 years, it works out much cheaper than all contraception. Go to the next slide. This is quite a lot of text, but it just shows you the addition to the standard treatment guidelines. So I'll just highlight a few things that's important there. The first thing is the HIV infection. So it can be used in a patient that is well controlled on HIV medication, so it is stable. And if the patient becomes positive, it is not a reason to remove the device. And there's also no evidence that it increased the risk of transmission either to another partner, or it also does not increase your risk of becoming HIV positive if you use the device. So that's quite good news. It has to be inserted by someone that's specially trained, but it's a very quick training. It's not that difficult. And it can be done anytime during the menstrual cycle. The advantage is like the copper IUCD, it can be inserted immediately post-delivery. You just need to provide that has specific training in postpartum insertion, and so it can be done within the first 2 days after delivery as well, and then it is just as effective. And the contraindications, everything is there. I'm not going to go through them all for the interest of time, because I've already 2 minutes over my time. But then just at the bottom, the referral. So a referral to the next level of care would be if there's excessive pain or bleeding after insertion, because there's a very small risk that there might have been a perforation of the uterus, or if there's signs of infection within 7 days, or if there's abnormal bleeding that persists for more than 3 months. So the ideal candidate for using this for contraception is the person that wants to space at least 5 years or more for the next pregnancy, and also maybe struggling with dysmenorrhea, painful menstruation, or abnormal uterine bleeding, and they will get all the benefits of the levonorgestrel device. That is everything from my side. Thank you very much.
Thanks very much, Stefan, and I'm glad you managed to go briskly through quite a lot of evidence and information. And I hope we'll have time for questions. Well, we will have time for questions just now. So I think the key next step is to go on to our third speaker, and that is Ms. Joyce Quincy. And she's, as you know, from the department, and going to talk to us about the Early Newborn Action Plan. So Joyce, it's over to you.
Thank you very much. Good afternoon, colleagues. Okay, I'm going to be presenting to you, colleagues, the Every Newborn Action Plan and the Ending Preventable Maternal Mortality in South Africa. Is just a brief of our national and global obligations, illustration of some of the contributory factors of maternal and neonatal mortality from Saving Mothers and Saving Babies reports. And also, I'm going to be sharing with you the INAP EPMM targets. These are the global targets that we are aligning ourselves with. And I'm also going to be sharing some of the interventions, the key interventions and strategies that we need to be using that are recommended to reduce maternal and neonatal mortality. These are the global obligations for INAP EPMM. We know that we have got the SDGs 2030, where we are supposed to be reducing maternal mortality below 70, as well as the neonatal mortality below 12 by 2030. And we also have got the global Every Woman, Every Child strategy 2030, which also recommends that we reduce maternal and neonatal mortality below the similar targets. And recently, in early May 2024, the World Health Assembly set, and they also reiterate that we need to be reducing, accelerating our actions towards progress for reduction of maternal and neonatal mortality. This slide talks to the national strategic goals and targets. As you can see there, colleagues, I don't have much time. I've got a lot of busy slides. So as you can see, colleagues, we have got the NDP 2030, which also reiterates reduction of neonatal and maternal mortality. Even the strategic plan 2020-2025, our target was 100 then from the department side, although we know that we are moving towards 70, as well as currently our target is below 10. For neonatal mortality, we are really working hard towards the target, which is a bit hard currently to reduce. We also have got the National Performance Plan, Annual Performance Plan 2024-2025. With those targets there, colleagues, we need to be reducing neonatal mortality below 10, as well as the stillbirths below 20. And we also have to improve the postnatal care to 95. We also have got the MTSF, the midterm strategic plan, which is ending this year. Also, it has got the targets that we are really fighting to be getting right. So our key goals as a program in the National Department of Health, we need to be improving antenatal care. We need to take care of maternal infections, which are a key contributor to mortality for both mothers and neonates. We saw from the drugs that were shared, some of the drugs we are supposed to be controlling the maternal infections, and we also have to control the complications during labor and postpartum, and we also have got to have a management for the small and the sick neonates so that we end those mortalities. These are the key global documents, colleagues, of ENAP EPMM, started in 2014 with ENAP, then the SDGs, the strategies for EPMM in 2016, and the global strategy for every woman, every child in 2016 also, and as well as strategies for reducing stillbirths. I think it was around 2017, 2018. Those are the global documents that we are aligning with, that we are drawing strategies to reduce maternal mortality and neonatal mortality. Now, these are the key global ENAP EPMM targets, the 90-90-80-80. We are trying to popularize these targets because we are going to be reporting in 2025, we're going to be reporting, and these are the targets which we are chasing towards the 2030. We are supposed to increase the antenatal care to 4 visits or more. We also have got to have a 90% of skilled birth attendants and skilled care during intrapartum. And we also have to have 80% of early postnatal care, as well as essential care for our newborns, and 80% of availability of emergency care. We know that emergency care is a challenge in our country because of lack of skill and lack of transport to the emergency areas. We also have to improve on our social determinants information to our women so that they are able to make decisions in terms of family planning and planning for their pregnancy, and as well as being able to make decisions when there are complications to go to the facilities and be aware of all the danger signs which are contributing to mortality. Here, colleagues, I just wanted to share with you some of the indicators from both the Saving Mothers, the Saving Babies report, as well as from the DHIS. These are our coverage indicators, which are indicating how far we are with the antenatal care as well as the delivery in facility, which is a proxy for skilled birth attendants, as well as those mothers who are delivering before arrival, which we shouldn't be having. And these are aligned to the targets, the global INAP EPMM targets, although we are taking the antenatal first visit before 20 weeks, but our goal is for mothers to attend all the 8 visits during antenatal, so that all the complications are managed during antenatal. So you can see that we are still struggling with our antenatal first visit. We are hovering around 68, 69, and we know that we are supposed to be going to 65 and also to 90 as per global target. This is just a glimpse of how we look, as well as how the provinces look in terms of the mortality indicators. We can see that under neonatal mortality, we are all red as provinces, and the leading one is Free State, which is at 18.7 for newborn. It is quite concerning. It's only the Western Cape, which is only at 8.3 per 1,000 live births. But otherwise, as a country, we are at 13.4, and it's quite worrying. For maternal mortality, we're at 100.6. We were coming very well as a country, and COVID disturbed us a little bit, but we are really fighting very hard for to reduce the mortality. And because we are saying one mother who dies, it's one too many. Even the stillbirths there, we are quite concerned with the stillbirths. They are quite high. We know that we are supposed to reduce to below 12, but we are at 20.7. This is just the trend, the 10-year trend for our mortality. You see that at least it's comforting that it's at least a downward trend. The one that arose there, it was around COVID in 2020, 2021. Currently, we are at 109.7. This is according to the Saving Mothers 2020-2022 report. So from this slide here, I just wanted to share with you, colleagues, it is in the Saving Mothers report. We have shared the Saving Mothers report with you. You can see that the causes of maternal mortality, HIV is the leading one, and the non-pregnancy related infections, which is mainly HIV, 1,063 mothers died from HIV related conditions. And the second one there is obstetric causes, obstetric hemorrhage causes. You can see that about 51.4% of mothers died from obstetric hemorrhages, which is quite a huge number. And hence all these drugs that, new drugs that we have so that we can control the PPH. Okay, I'm not going to go through it. Colleagues will share the slides with you so that you can see. These are the key indicators, colleagues, key interventions that we have currently, that we need to provide them, in a quality manner. We do have good interventions. You can see there the emotive, we have it there as one of the, which has just been presented. These are the good interventions that we have as a country, but our challenge is quality implementation of all these good interventions. Hence, we still have mothers dying, yet we have good interventions. You can see that this is a 2017-2019 pie, which was indicating from the Saving Mothers report, which was indicating the causes of maternal mortality. You can see there. And these ones are the 5 key recommendations for the 5 H's. the hypertension, the HIV, the hemorrhage, the heart conditions, as well as the management during early pregnancy, which is what we are seeing, that it's what it is causing the poor management during antenatal, it translate into, poor management in intrapartum care and towards along the continuum. So for neonatal mortality in the country, even here, it is quite a major concern, as you have seen in that initial slide that I've shared. We've got about 20,000 stillbirths annually and 10,000 neonates dying. And these are only the in-facility data that we have collected via the PPIP. As you can see there, the slide here is for stillbirths as well as the neonatal mortality. You can see there, the Free State is still going. It's high, followed by Eastern Cape as well as the Northern Cape and KZN. Also, these pies, they just illustrate here what are the key causes of our newborn. Is the hypoxia, immaturity-related infection, as well as congenital abnormalities are now quite rising as one of the causes of our newborn deaths. These are in the Saving Babies report. We have also shared the Saving Babies report. You'll get all the data within that report, colleagues. And as this is just an illustration of neonatal mortality, as I've indicated, the immaturity related, you can see we had about 2.247 babies dying from immaturity related hypoxia, about over 1,000. And as well as infection there. And with infection, colleagues, we know that we now have a rise of syphilis, and also, as I indicated earlier, HIV-related conditions also contributing to our neonatal mortality. These are the key. Happy for new interventions that we have, colleagues. They started way back. We only need to improve on their implementation and implement in a quite quality manner. We do have, as a country, good interventions. Next slide. These interventions here, these are from the global INAP EPMM plan, how we are supposed to reach all those indicators, the 90-90, 80-80. These are also aligned to what we have in the country. As I say, colleagues, the interventions we do have, they're aligned to the global INAP EPMM plans. Next slide. These are the proposed measures of quality. These are the process indicators of what is it that we can do to try to track ourselves. These are not in the DHIS or in the PPIP. Maybe with innovation we can develop some apps or some apps just to try to track the process indicators so that we can track ourselves. As it is the antenatal 4+ visits, we are using the DHS, and the DHS is not an annual reporting tool. So we may have to have ideas how we can track some so that we can see ourselves that we are on track. Next slide, please. What has been a progress so far, colleagues, as a country? Yes, we have been collaborating with partners, we've been working together with all the key people around maternal and neonatal. We've recently developed the INAP EPMM technical working group, so that those interventions that we have and the key plans that we have within the INAP EPMM, we implement them. We have a 5-stream within the INAP EPMM technical working group, and we hope that all the interventions that we have in the plan, we are going to be implementing them. And we do also have the guidelines, which we are going to be rolling out online. And we also have the policy, which was recently signed off. So that's the progress, colleagues. We still need resources. We still need to collaborate with all the stakeholders who can fund us to support us to implement all the key high-level action points from the National Department of Health, so that we can support the provinces and facilities and frontline workers to be able to implement all the key strategies to reduce maternal and neonatal mortality. So WHO, UNICEF, and UNFPA are our key supporting UN agencies partners. For now, recently we've been to Zambia to report on the very INAP EPMM plan in terms of the progress. So they are the key supporting partners for us for now, but we are still making a call. If there are partners out there who can support us as a department, in terms of funding, in terms of technical skills, come and join the technical working group so that we can work together to reduce mortality in our country. Thank you very much.
Thanks very much, Joyce. I think we all enjoyed that and learned quite a lot from your overview of the department's direction in terms of neonatal and maternal care. And we can now move on to our next section, which is essentially to have some coverage of any burning questions that people have, seeing as we've finished the more structured part of the webinar. I don't know if members of the team would like to decide on how we want to take these questions, or if there are any burning questions you want to address to people from what's appeared already in the question and answer session. A lot of the questions that I've looked at seem to be related to this topic, but not directly answerable from our perspective as a Essential Medicine Foundation group, but also obviously relating to what Joyce has said, and she may want to take on some of them. Stefan, is there any questions you saw in the Q&A thing that you'd particularly like to address as a starting rollout for our responses? And then if there's anybody else in the Secretariat or elsewhere who's seen something they think we should address, please feel free to chirp about that and we'll take it on.
Okay, I'm just discussing the questions that was already answered in the text, but two of them was about the intrauterine device used during cesarean section, and I've answered there that we can do that. You can insert it after the baby and the placenta has been removed, just before you close the uterus. There is a slightly higher expulsion rate. So some people recommend that you just tie the intrauterine device with a small copper suture to the uterine wall. But if you just place it well and then follow up after 4 weeks just to trim the strings a bit, it can be done at cesarean section, just as this can be done after delivery. And then the other question, but that is not something I can answer. I've seen two people asked about the options for availability of progesterone, the vaginal progesterone, which is a tender issue. We do have an option in the Western Cape, so we use utrogestin. But I'm not sure if maybe Marupeng or somebody can, or Mali can answer from the other side, how we go about to get progesterone available.
Yes, thank you, Prof. We have reached out to the contracting unit for them to to advise on how people can access it. It is an EML product. However, for some reason, it was not included in the contract. So I think we will be arranging a buyout, but we will liaise with them and see what is the status today. If there are questions, you can just drop us an email and then we'll follow up.
Thanks. And then the other question was around tranexamic acid intravenous. So I think it's just clarity that it's not the oral version we're talking about, which is being used for other indications for menorrhagia or for heavy bleeding. This is specifically intravenous given 3 hours or within 3 hours of the event to decrease the risk of further bleeding. So just to clarify that. So that has been added. And I think the other question was around hepatitis B, whether we should vaccinate all pregnant women. And I know Dr. Moran is on this meeting as well, and he may best answer that question. So I've tried to answer it as best I can. We are awaiting the national guideline, which isn't out yet. The previous version has recommended that. So all women that were born after 95 should have received the vaccination at birth already or within the 6 weeks as part of the EPI schedule. At this stage, if they are hepatitis B negative and at very high risk of obtaining hepatitis B, you can recommend getting vaccination. It is safe in pregnancy. But I don't think we're at the point yet where we're going to vaccinate all women who are negative. I'm not sure, Neil, if you want to comment on that, if you can. I'm not sure if you're able to talk. Or maybe somebody else on the call. And then, yeah, I think we've covered everything that was in the test. I'll just check what open questions there are.
We still have about 12 open questions. If we can't get through all of them, we will try to answer these and post the responses on the
I'll
knowledge.
start. The first one is from Angela. You could see it says, is DM incidence not a problem during pregnancy? I'm not sure what DM is. Is it diabetes mellitus or is it something?
I think that's diabetes mellitus, yeah.
Okay, so yeah, diabetes is really a problem during pregnancy, especially in obese patients. We have been recommending testing at booking and at 26 weeks in high-risk women for diabetes since 2017 already. It's also in the maternity care guideline. In the Western Cape, where we do quite a lot of glucose tolerance testing for diabetes, we have a huge amount of diabetes in pregnancy, so it really is a problem. It is a challenge. And there are specific indications for testing at 26 weeks. It's BMI above 35, age above 40, previous big baby. So just it is in the guidelines. Ideally, we'd like to do universal testing of all pregnant women, but that's a bit expensive. So we just do targeted testing, but it is at booking and at 26 weeks. The second question is one of those that we can't really answer from this side, but maybe Joyce can. It's about intrauterine device insertion training, where we can access that training. I'm not sure if that is on the Knowledge Hub, but I know there are courses that are being offered. So maybe that's a question that Joyce can answer, or somebody from programs. And then the next question is just a reminder that there are rare reasons for hemorrhage as well, which is hemophilia or von Willebrand's disease or protein S deficiency. So women with bleeding disorders, they all should qualify for tertiary care, fetal maternal medicine care. So they should be referred as soon as they're identified if they're known to be hemophilic. It is going to be difficult to test all women if we don't suspect it, because it's quite a rare incidence. So I think the moment the woman does have a bleeding tendency or comes from a high-risk family or is known to have a bleeding coagulation disorder, she needs to be referred for tertiary care. Then there's a question. I saw that aspirin is initiated from 6 weeks before 16 weeks. Is it contraindicated to after 16 weeks as we get clients who book late? It's not contraindicated, but you don't really get any advantage of giving it after 16 weeks. Because I said it's that first wave of placentation that takes place in the first trimester that we really need the aspirin for. But there is also a slight benefit after 16 weeks where it has to do with balancing the thromboxane and prostaglandin in the blood, so it won't do harm, but it's best to try to initiate it as early as possible before 16 weeks. Then the next one is, please can we have an indication if the other new vaccine introduction will be included in the updated standard treatment guideline? The other new vaccine introductions. So not sure what vaccines we are discussing there. Maybe it is Tdap, which is already available, is already rolled out. So for pregnant women, the Tdap should be given in the 3rd trimester. And the recommendation is if we don't have anything else to go on, like history of tetanus vaccinations, to give Tdap in each pregnancy in the 3rd trimester. Hepatitis B vaccination is covered in the maternity care guideline. But maybe somebody from NIMLA can answer the question about what other vaccines are in the STG vaccination chapter. I don't have access to that. I see Dr. Moran cannot talk, but we can answer that question afterwards then. So I'll keep on until somebody from the NIMLAC list can talk about the vaccine introductions. The next question, the way forward, Marina, essential. What is the percentage of planned pregnancy? How can you start? How young can you start? How young can you start with Marina? Anytime. Somebody did comment that it is a little bit more difficult to insert it in somebody who hasn't delivered a baby before, even though it's not a contraindication. As I said, you need just to have that special training to dilate the cervix a little bit to insert the Mirena, but it can be done even in young women or patients who haven't delivered previously. If you struggle, you can just refer it to, it doesn't need to be a specialist or a gynae, you can just refer it to a doctor or somebody with more experience. But obviously you won't give Mirena if the patient or the woman plans a pregnancy within the next year or 2, because then it's going to be not cost effective. So really, if it's at the end of, she doesn't want any more pregnancies, or is a teenager who had a pregnancy and wants to wait at least 5 years before the next pregnancy, that's the ideal candidate to give that. But there's not a cutoff of how young you can start. The smaller the device, the 19 milligram one, is still very expensive, but it is a little bit more easy to get in, especially for younger people. So once that becomes available at a cheaper option, that will be ideal one to do. Okay, the next question is for Joyce. It says, is there any institutions in Africa where you can study neonatology postgraduate for nurses? I think that's something that we can answer in an email. And then it is, this is not beneficial after 16 weeks. We've covered that. It's best to start before 16 weeks. But because most patients book late, there is still a little bit of a benefit if you give it after 16 weeks. So it's not contraindicated. Neil has now answered in the text. Thanks for that. For now, the priority should be to offer hepatitis B vaccination to people at highest risk for contracting hepatitis B, such as health workers, because there's a limited stock of the vaccine. So vaccinating all hepatitis B negative pregnant women should not be immediately feasible. The value of such a strategy is being reviewed by the National Advisory Group on Immunization, and they will provide recommendations in due course to the Minister of Health. Thanks, Dr. Moran. I think that's more or less how I answered it as well. So keep the vaccination for those people at highest risk of obtaining the virus until we have more clarity on that. And again, I think the focus is, if somebody is hepatitis B positive, make them or arrange that they deliver in a facility where we can give vaccination to the baby at birth, because the baby will only get it at 6 weeks according to the EPI schedule. Next question is also for Joyce. I want to know if the hard copy of the maternal guideline is available and where I can find them. I see somebody is typing an answer to that, but it's, as far as I know, still at the design stage. Next question, request that the National Department of Health through a circular until updated guidelines are out, because the old ones say they must be back. Yeah, so we are in a transition phase. We've already introduced the maternity care guideline via webinars in March, but the guideline itself is still not printed. Maybe Ms. Mouncy can answer on that. But the guideline is finalized, it just needs to be signed off, and it is at the at the printers, as far as I know, but we are stuck a bit because medico-legally we're not sure which guideline we're following at the moment. Next question, can I do APH on Knowledge Hub? And is recognized in the workplace as an edit? I don't know what that is. Then it's preventable maternal deaths and what percentage of maternal deaths is preventable. There is the Saving Mothers reports and all of the data about the preventable maternal deaths, the bulk of them are preventable, is in the Saving Mothers reports, which Joyce have now also highlighted. And those reports have already been circulated, the last Tranexamic reports. So all of that data should be available. Should family planning be introduced as part of high school life orientation? Again, outside of my scope. So if somebody else can answer it, I really feel it should be, but it's not something I can answer. If a patient has gestational DBM, which I assume is diabetes or hypertension, how long must they stay post-delivery on meds? Okay, so that's also a guideline question from the maternity care guideline, not necessarily standard treatment guidelines, but I'll quickly answer that. If it's gestational diabetes, so first diagnosed in pregnancy and no overt criteria are met, so we don't suspect that it's diabetes that originated before pregnancy, we stop the medication again directly after delivery. If it's gestational hypertension, so again, not chronic hypertension, you can stop the medication after delivery, depending on how severe the blood pressure is. But any patient that had chronic diabetes or chronic hypertension before pregnancy will usually go back to the doses they were on before pregnancy. But this is covered in the maternity care guideline, and hopefully that will be available soon. Okay, so that question's been answered. Is doing oral glucose tolerance test before 24 weeks recommended as baseline for high-risk patients? Yes. As I said, the recommendation is to test at booking and again at 24 to 26 weeks. That's the formal oral glucose tolerance test. So that is standard, and it's been like that since 2017. So that is nothing new. We have been giving methyl dopa as treatment for hypertension in pregnancy. So now will aspirin be added to that treatment? Yes. Just remember that the aspirin is not treatment for the hypertension. It is to prevent preeclampsia or superimposed preeclampsia from developing early on or later on in pregnancy. It doesn't prevent it at all completely, but it is a substantial reduction in the risk. So the methyl dopa is for hypertension. The aspirin is to prevent further complications. So both, but the aspirin you just take at bedtime to prevent gastric irritation. That question just says, and neonate, so I don't have the rest of the question. May I ask if the HPV vaccine is going to have safe application on pregnant women with a negative HPV from a pap smear done during pregnancy? Or should we err on the side of caution by not vaccinating pregnancy, as currently vaccinations for under years old, but the results from pap smear may recommend HPV vaccination? At this stage, HPV vaccination is safe in pregnancy if it's given inadvertently. It's not going to be a problem. But we don't recommend that you vaccinate against HPV in pregnancy. And again, HPV should be given, as the person there says, before you become sexually active for it to be effective. So once you're pregnant, you've been sexually active, you've been exposed to the virus. So even if a pap smear result or a lipid-based cytology says HPV negative, it doesn't really have the same effect if you vaccinate that woman. It has to be done before you are sexually active. But if you give it by accident and the patient is pregnant, it's not going to do harm. Next question, for prophylactic reasons, can we still give aspirin in subsequent pregnancy if the patient only had gestational hypertension without having to develop preeclampsia throughout their pregnancy? Yes, you can still give it in subsequent pregnancies because the risk remains. A patient may have early onset preeclampsia, 2 normal pregnancies, and again early onset preeclampsia in a later pregnancy, so that risk remains. And for up to how long can we continue aspirin? Until 36 weeks, because after 36 weeks, it doesn't reduce anything anymore, but it does increase the risk of bleeding in the mother and the baby, so we stop at 36 weeks. I think the last question there, Joyce is typing an answer at the moment. Okay, so I've exhausted all the questions that I can answer.
Thanks very much, Stefan. You've done an amazing job there. I think we've had over 80 questions, and that's quite an impressive number that people have answered, which is 58 out of the 80 odd. So well done for that. If there's any other members of the team who'd like to address any of the other questions that came up or make any further points before we close out, now's the time to do so. Anybody else got anything further to add or answer?
Thank you, Prof.
Okay, Mariping, so there's nothing else from your side and nothing else from the Secretariat side in general. I think it's really up to me then just to thank all the presenters and especially thank all the people who joined this webinar. I'm really delighted that we had this opportunity to chat to you about these issues, and I hope we can continue this series. It's very close to the heart of all of us. It's Essential Medicines program that we do carry on communicating with you guys. So thank you for joining us and all the best for the rest of your day. And I'll call it over and out then. Thanks once again. Cheerio.
Thanks. Bye-bye.
Bye.
Bye.
Thank you, everyone. Bye-bye.
Bye.
Thank you, Joyce.